Good morning. I'm Dr. Anria Horn, one of the orthopedic surgeons working at Red Cross Hospital. Today we'll be talking about an approach to common musculoskeletal complaints in children. When a child presents to you with an orthopedic or musculoskeletal complaint, their complaint will usually fall into one of the following categories: pain, which may be described as aches or cramps, limping or a funny walk, and deformity, which parents will usually describe as skewness or turning in or out. Of course, there may also be a combination of these features. Pain most commonly presents in the feet and the legs, with the back and multiple joints being less frequently the source of presentation. When assessing a child, it is important to find out when the pain occurs, as this may help you to reach a diagnosis. Night pain is typically associated with infections or tumors. Pain upon rising is typically a feature of inflammatory arthritis. Pain during activity usually is a result of an overuse injury, similar with following activity. Pain in the late afternoon and early evening is quite typical of growing pains, whereas constant pain is rather concerning and usually has a more sinister source. It is important to elicit whether or not there was a precipitating event that led to the onset of the pain. How long has the pain been present, and was there a history of trauma? Most parents will report a traumatic event, but this may be spurious or a red herring. As you well know, children tend to be clumsy, especially the younger ones, and fall on a daily basis. It's also important to ask what relieves the pain. Rest, rubbing or massage, ointments and oils, heat, or analgesia. And in the case of analgesia, which analgesia and how frequently is it required? Ask about associated symptoms, limping or pseudoparalysis of the upper limb, neurological symptoms such as paresthesia, bowel and bladder symptoms, constitutional symptoms such as fatigue, loss of weight and loss of appetite, which may be suggestive of a chronic infection or malignancy. Is there an associated fever? Is there anything else? Having taken a thorough history, it is often possible to narrow down the potential or provisional diagnosis to a few common conditions. Foot pain is most frequently either idiopathic, a result of flatfoot, result of tarsal coalition, Sever's disease, infection, inflammation, or stress fracture. Leg pain may be idiopathic, may be growing pains. It could be neurological if there's an associated spinal problem, stress fractures, malignancy, hypermobility, and Osgood Schlotter's disease. Joint pains or multiple joint pains is usually a result of inflammatory conditions, reactive arthritis, or infection. And back pain, mostly mechanical or idiopathic, but could be a result of infection, Scheuermann's kyphosis, spondylodiscitis, scoliosis, tumors, or systemic arthropathies. We will be touching on most of these conditions briefly. It is also important to know that pain may very well be a psychosomatic presentation as a result of an underlying stress. In my experience, bullying is quite often a cause for a patient to present with vague complaints of pain. It's also important to look for signs of domestic stress or violence and child abuse. For example, this young man presented to me with a very strange spinal deformity and back pain. Multiple investigations were performed, including blood tests and an MRI, and absolutely no abnormality was elicited. On further questioning and consultation with the parents and other family friends, it became evident that this child has been sexually abused and was also experiencing difficulties at school. So flatfoot is by far the most common reason for pediatric orthopedic referral. Flatfoot is also known as pes planus or pes planovalgus. When thinking about physiological flat feet, it is important to know that all children under 2 years will have flatfoot. This is because of the thickened fat pad in the sole of the foot and the ligamentous laxity associated with youth. Most children will develop an arch by the age of 8 years. There's an associated short Achilles tendon in 25% of patients, and this should also be examined or elicited during your examination. But the mere presence of flat foot is not an indication for treatment or referral. Why do patients present with flat feet? Mostly it's because of parental concern regarding the appearance of the feet. Parents will often describe it as no arch or the foot turning outwards. Parents are also concerned about long-term effects on the hip and the spine or other issues with balance. Shoe wear can also be a major concern. This is an example of a child with a unilateral severe flat foot, where you can see the medial part of his shoe is completely worn out from walking on it. So when you assess the patient with a flat foot, it's important to elicit from the history whether or not there's pain and where the pain is. Does the patient have fatigue in the lower limbs? Is shoe wear a problem? And does the child suffer frequent sprains? On examination, you must determine whether or not the foot is flexible or stiff, whether there are any callosities, and whether there is shortening of the Achilles tendon. A child's normal range of dorsiflexion should be approximately 20 degrees with the knee extended. This is an example of a flexible flat foot. As you can see, when the patient's standing, the heel is in slight valgus. However, as soon as she raises up on her toes, the heel turns into varus. This is normal and it's because of mobility of the subtalar joint. If this is not present, the flat foot is stiff and hence pathological and should be referred for further assessment. When is treatment indicated for a physiological flat foot? Well, if there is subfibular impingement, which will lead to pain on the lateral side of the ankle, if there's pain over the talar head or the navicular due to abnormal weight bearing, and if there's pain and fatigue in the lower legs. The first line of treatment will be a trial of orthotics and simple analgesia as required. But what about orthotics? What does the evidence say? This is a very good article on the management of pediatric flatfoot, which I recommend you read. Orthotics is seldom indicated. It does not change the natural history of the flat foot. Once you remove the orthotic, the foot will remain flat. And it is really only indicated if the patient is symptomatic. There is some evidence to suggest that children with flat feet who wear orthotics actually have more psychological and self-image issues than patients who are not treated with orthotics. And furthermore, off-the-shelf orthotics are as effective as expensive custom-made ones. No special shoes are required for a patient with flat foot. If the flat foot is in fact stiff or severely painful, the patient needs to be referred to a pediatric orthopedic surgeon. The list of reasons for pathological flat feet can be quite long, but includes tarsal coalition, neuromuscular causes such as cerebral palsy, and infection or inflammation in the subtalar joint. This was an interesting study that looked at the reasons for patients presenting with musculoskeletal pain. Not surprisingly, the majority of patients had pain because of trauma or mechanical overuse, but there were quite a few other causes of presentation as well. So let's talk about growing pains. What is growing pains actually? Growing pains is intermittent. It is usually bilateral and symmetrical. It presents on the anterior thigh and the calf, as well as posterior to the knee, usually worst in the late afternoon or early evening. The patient will have no limitation of function, no abnormalities on examination, and normal radiological and blood investigations. What else do we know about growing pains? Well, it's common. So more than a third of children between 4 and 6 years of age will report symptoms associated with growing pains. We also know it is unrelated to foot posture. Patients with growing pains generally have a lower pain threshold than patients who do not have growing pains. Ultrasound has shown decreased tibial bone density, which may lead to bone fatigue. There's a possible association with hypermobility, Patients that have increased activity are more prone to suffer from growing pains, and these are often moody children with a family history of migraine. What's the treatment for growing pains? Simple reassurance, as this is a self-limiting and completely benign condition. Muscle stretching programs have been proven to be the best treatment for growing pains, and simple leg rubs, heat and rest has also been effective in managing the symptoms. Joint hypermobility syndrome, also known as Ehlers-Danlos type 3, is quite a neglected and underestimated condition. According to the literature, this is a poorly understood, easily dismissed, and poorly treated condition. What it actually is a progressive pain syndrome and a multi-organ disease. It is common, it affects up to 2% of people, but quite variable expressions, and as previously noted, simple joint hypermobility syndrome is indistinguishable from Ehlers-Danlos hypermobility type 3. Patients will present in the first decade of life with delayed motor milestones, poor coordination, hypotonia, frequent sprains, patellar dislocation, and other painful symptoms. In the second decade, they may complain of recurrent arthralgias, back pain, tenosynovitis, myalgia, hyperalgesia, and regular falls. These patients also suffer from other system disorders. In the first decade, they may complain of headache, fatigability, constipation, bronchial hyperreactivity, food sensitivity, and bladder dysmotility. These symptoms progress to recurrent headaches, neck pain, poor sleep, irregular periods, dysmenorrhea, and functional GIT disorders in the second decade of life. This flowchart describes a vicious cycle leading to a chronic pain syndrome in patients with joint hypermobility syndrome. Any small injury or repetitive injury may lead to these symptoms here, which include kinesiophobia, deconditioning, fatigue, disability, dependency, and chronic pain. It is important to recognize this quite early on and start physical rehabilitation as soon as possible. Cognitive behavioral therapy is also quite effective for these patients, as it is not a purely musculoskeletal condition, and treatment therapies associated include psychologists, physiotherapists, OTs, as well as rheumatologists. So overuse injuries in children has become a much bigger problem of late, and has been the focus of attention in many studies. And this is most likely due to the increased activity and increased participation in competitive sports that we see amongst younger children and adolescents these days. So the definition of an overuse injury is an injury resulting from repetitive loading or stress to elements of the musculoskeletal system where inadequate time is granted to allow for healing to take place. Common overuse injuries seen in children is spondylolisthesis, as illustrated in this X-ray, and this is usually associated with sports where there's a lot of spinal hyperextension involved, such as ballet, gymnastics, and bowling. Femoral neck stress fractures may occur in long-distance runners with menstrual dysfunction, and in Osgood Schlatter and Sever's disease is also a common cause for presenting with musculoskeletal pain. Factors that contribute to injury in the young child is the intrinsic weakness of the cartilage compared to adult bone. The adolescent growth spurt places quite a lot of strain on the skeleton as it keeps growing with the inability to mineralize at an adequate speed. Certain anatomical variants can lead to injury, menstrual dysfunction, and poor conditioning. How menstrual dysfunction works, of course, is that once in teenagers that lose most of their body fat, they will have lower estrogen, and as a result basically develop osteoporosis similar to what's seen in menopause. So how can you avoid overuse injury? The patients need to rest at least 1 day a week during the training season. Decrease training during the off-season. Vary their activities. Don't let them just run. Let them also swim, cycle. Consider doing low-impact activities to remain fit, such as swimming and cycling again. Perform age-appropriate activities. And pay attention to the equipment being used and the patient's condition. Osgood Schlatter's disease is quite a common overuse injury, especially in boys. But nowadays, according to the most recent literature, girls are equally affected. This is caused by a traction apophysitis of the tibial tuberosity and is more common during the adolescent growth spurt. Why this occurs is, if you think about it, the entire bulk of the quadriceps muscle is conveyed into this tiny bony ossicle, which is not able to withstand the stress of repetitive running and loading. And what happens then is that you actually get minor fractures of the tibial tuberosity as it pulls off, and this will lead to the swelling and pain that you see clinically with Osgood Schlatter's disease. This condition can be managed conservatively in more than 90% of patients with rest, analgesia, and activity modification, and it is self-limiting once the growth plates fuse, as skeletal maturity is achieved. In a very small proportion of patients, surgery has been indicated. Sever's disease is traction apophysitis of the calcaneal tuberosity. It is also an overuse injury and is more common in pre-adolescents than in adolescents. The management is always conservative, and a heel raise is the very effective way of managing the pain. A stretching program to stretch the shortened gastrocnemius and hamstring muscle groups is essential for the management of this condition, and of course activity modification and rest. It is also important to know that sclerosis of the apophysis of the tibial tuberosity is not diagnostic of Sever's disease. However, fragmentation of the tuberosity is seen more commonly in patients with Sever's disease when compared to their normal peers. What about cancer? I suppose when a patient presents with bone pain, cancer should always be at the back of your mind. However, it is one of the least common causes of bone pain in children. This was an excellent article published in the Journal of Pediatric Orthopedics in 2008. The authors looked at 122 patients who had acute leukemia, and of those, 47 patients had musculoskeletal complaints at presentation. This included pain, functional impairment, limping, swelling, or a joint effusion. In their cohort, the male to female ratio was 1.5 to 1, the age ranged from 7 months to 17 years, and the site of the bony pain was quite unhelpful in making a diagnosis. What was very interesting though, is that of the 122 patients in this study, each one of them had a constitutional symptom or sign. 100% of the patients had pallor. Some had hepatosplenomegaly, lymphadenopathy, fever, lethargy, bleeding, or anorexia. And this is reassuring to know, because if you have a patient with vague bone pain and absolutely no other signs or symptoms, it is highly unlikely to be as a result of a hematological malignancy. When talking about bone pain, one has to think about bone infections as well, as this can be quite severe and have devastating consequences if not treated appropriately. The three groups of bone infections we'll be talking about is osteomyelitis, septic arthritis, tuberculosis, and spondylodiscitis. In pyogenic infections, which is quite common in young children, the key clinical findings will be limping or an inability to walk, pseudoparalysis of the upper limb, swelling or effusion, warmth, redness, and quite frequently a cutaneous infective lesion. Younger children are more commonly affected than older children as far as osteomyelitis and septic arthritis is concerned, and there will often be a history of trauma, which Kocher Criteria was initially described to distinguish septic arthritis of the hip from transient synovitis of the hip. However, in my practice, I find it quite useful to diagnose bone and joint infection involving other limbs. The criteria are non-weight bearing or pseudoparalysis in the case of a non-walker with upper limb, ESR of more than 40, white cells of more than 12, and a temperature of 38 degrees. As you can see, the likelihood of bone infection or septic arthritis being present increases exponentially the more criteria is present. The beauty of this system is that these are readily available blood tests and are also inexpensive, therefore available even in rural hospitals. A common confusing situation is whether or not there is septic arthritis or indeed cellulitis of the limb. I suppose this is important for us because cellulitis is treated by the general surgeons and septic arthritis by orthopedic surgeons, so we often have this argument. If the patient is unable to move the joint, that is septic arthritis. If there is subcutaneous pus or an abscess, it's far more likely to be cellulitis, as pus is often contained in the joint by the thick capsule. Induration of the skin is also more typical of cellulitis, as is an absence of an effusion of the joint. But even with all this helpful information, it can still often be a diagnostic dilemma. Musculoskeletal TB should also always be in the back of your mind when a patient presents with bone pain. TB is endemic in the Western Cape, with 1 out of 100 patients being infected. So it's important to always have a high index of suspicion. There may or may not be a history of weight loss, night sweats, or TB contact, but in a recent review we found that only about 30% of patients have associated symptoms. In TB, there's often an insidious onset of pain, no pain or swelling. It's a cold abscess that lacks the usual signs of inflammation, which we know is rubor, tumor, calor, and dolor. And in the pediatric population, a positive Mantoux test is quite suggestive. Spondylodiscitis should also be concerned or considered when the patient presents with limping or inability to move the leg. But this is a case that I treated as a registrar, and the patient presented with the inability to weight beyond the left, and that the typical posturing of the left hip didn't want to move the hip, and I was convinced it was a septic arthritis. However, I did ask for an X-ray of the lumbar spine to exclude any underlying pathology, and as you can see there's complete destruction of L5, and this patient turned out to have a psoas abscess with an underlying TB of the spine. So always examine the patient's back as well. Speaking of back pain, what do we know about back pain in the child and adolescent? Well, firstly, there's a rising incidence worldwide. Nobody's entirely sure why this is the case, but heavy backpacks are being blamed, obesity, and then increased activity as in sports, and then also decreased activity as in video games. Mostly back pain in the child is idiopathic and self-limiting with no serious or surgical underlying problem, but evidence suggests that 80% of children who have lower back pain will continue to have lower back pain as adults, and as we know, lower back pain is the single highest cause of loss of income and inability to work worldwide, with a major financial and economic impact. When examining a child with back pain or lower back pain, there's a few significant diagnoses that need to be excluded. Firstly, Sherman's kyphosis. This occurs generally in adolescent males. There's an associated kyphotic deformity and typically pain in the interscapular area. These patients very seldom require surgery but will benefit from stretching programs, strengthening programs, and if the deformity is severe or progressive, surgery is indicated. Spondylolysis or spondylolisthesis is a stress fracture of the pars interarticularis, usually at the level of L5 or S1. This will be a cause of lower back pain in active children, and especially those that participate in hyperextension sports. They will present with a hyperlordosis but with flattening of the buttocks. They may also have hamstring tightness and radiculopathy upon presentation. Certain seronegative arthropathies will present with back pain, specifically ankylosing spondylitis. These patients will typically have a history of morning pain and stiffness, associated joint pains in other joints, and a positive family history. This X-ray demonstrates sacroiliitis in a young man with ankylosing spondylitis. And then lastly, we always worry about tumors and infections. So a typical presentation with this would be localized bony pain and tenderness, constitutional symptoms, and often a mild associated scoliosis. All patients with a painful scoliosis should have further investigation in the form of an MRI. Multiple joint pains may also be an indication or a reason for presentation to a general practitioner. And in these instances, it's important to exclude or diagnose underlying inflammatory arthropathy. However, it is quite difficult to diagnose, and it is mostly clinical. There will be a history of morning stiffness and decreased activity. There may be pain, effusion, swelling, or reduced range of motion of the joint. There is unfortunately no specific blood test that can diagnose inflammatory arthritis, and early referral to rheumatology is indicated if this is suspected. Regarding the ANA and rheumatoid factor blood tests that's commonly performed, so ANA, if positive, is more suggestive of idiopathic inflammatory arthritis, and the importance of that test is that uveitis is more common in patients with ANA and positive ANA, and it also predicts for a more severe disease course. Same as with rheumatoid factor, is if it is positive, the child is more likely to have a more severe disease. In the differential for a patient with multiple joint pains, you should exclude hypermobility syndrome, reactive arthritis, which can be secondary to a bacterial or viral infection and often HIV, septic arthritis, of course, and psoriatic arthritis. So that's pain. Now, what about the limping child? Limps can be secondary to pain, of course, to deformity, to joint dysfunction, which may be because of a dislocation, muscle imbalance or pain, or a leg length discrepancy. Of course, this list is not exhaustive, but these are the most common reasons for a patient to present with a limp. In the case of a painful limp, these are the most important conditions to consider when assessing the patient. Injuries such as overuse injuries, infection, or inflammatory diseases such as JRA. We have already discussed all of those, so I will spend a little bit of time on Perthes disease and slipped upper femoral epiphysis or SHI. Perthes disease is an idiopathic avascular necrosis of the femoral head. It most commonly occurs in boys between the ages of 4 to 8 years old. We don't know why it happens, that's why it's called idiopathic, but there are certain conditions or certain associations, such as parental smoking, low socioeconomic class, and decreased bone age. The patient will present with an insidious onset limp and minor pain, and on examination you will find a decreased range of abduction and rotation of the hip. There may also be a fixed flexion deformity. When assessing the child for Perthes disease, it's very important to get 2 views of the hip. This is a young patient of mine when he presented, and even though there are subtle changes in the right hip compared to the left, these are not obvious. You can see there's slightly increased joint space due to early collapse of the femoral head. The femoral epiphysis is somewhat sclerotic compared to the left side, and there's widening of the neck again compared to the left side. However, on the frog leg lateral, there is no denying the fact that there's a subchondral fracture, which can be seen in this enlarged image here, and that is pathognomic of Perthes disease. These patients should also be referred urgently for orthopedic assessment. Slipped upper femoral epiphysis is unfortunately a frequently missed diagnosis, and not just by general practitioners but even by orthopedic surgeons. SUFI generally occurs in overweight pre-adolescent and adolescent patients. If a patient is not within this group, it is considered an atypical SUFI, and an underlying cause such as endocrine dysfunction needs to be sought. There may or may not be a history of trauma. Usually it is minor trauma, and the patient also typically presents with knee pain. In my experience, patients with a delayed diagnosis of SUFI often come to you with a normal knee x-ray and a few weeks later the abnormal hip x-ray. Patients with SUFI will clinically present with a painful limp or an inability to weight bear. The affected limb will be shortened and externally rotated, as is demonstrated in these clinical photographs. So you can see here the short externally rotated leg on the right, in this case on the left. There will also be a decreased range of abduction and flexion as seen in this clinical photograph. So like I said, hip or knee pain and limping, short leg externally rotated and reduced range of motion at the hip. It's very important to again take an AP and a frog leg lateral, as the diagnosis can be missed if we take only one view, and these patients also need to urgently be referred for. This is just such an example where on the AP there are some abnormalities on the, in the right hip certainly, but it's not extremely obvious and it will not necessarily be noted by the inexperienced eye. But on the lateral, there is no doubt that there is quite a marked slip of that epiphysis on the right. And the reason I'm saying that urgent referral is required is firstly, in your severe unstable SUFI, such as seen in this X-ray, there is a very high risk of developing avascular necrosis of the femoral head, and this condition is unfortunately irreversible, catastrophic, and will require a hip replacement at a very young age. And indeed, if you do not reduce it, then there's also a very high risk of osteoarthritis. So what about the painless limp? In these instances, these three conditions are the ones that I want to focus on: leg length discrepancy, developmental dysplasia of the hip, and Coxa Vara. If a patient presents to you with a leg length discrepancy, it's important to exclude an underlying hip pathology, as this is often associated. Note in this X-ray that this boy has complete avascular necrosis of the femoral head and a subluxation. This is a result of a hip infection at a young age, also known as Tom Smith's arthritis. Patients with a leg length discrepancy of less than 2 centimeters can usually be managed conservatively or with a shoe raise. In patients between the ages of 2 and with patients with discrepancies ranging from 2 to 5 centimeters, epiphysiodesis of the contralateral limb can be performed, and how this works is by doing a timed destruction of the growth plate on the long leg. One can allow the short leg to catch up and end up with approximately equal leg lengths at skeletal maturity. Patients with a leg length discrepancy of more than 5 centimeters usually require a form of bone lengthening. This slide is an example of a femur that was lengthened in the same patient as on the previous slide. It's called distraction osteogenesis. Osteotomy is performed and the bone is distracted 1 millimeter a day in 4 sessions until the desired length is achieved. And then in the wake of the traveling bone ends, new bone forms, as you can see here already, and here it's basically consolidated. And after removal of the external fixator device, it's advisable to put a nail down the shaft of the bone to avoid fracture, as the regenerate bone is generally not strong enough to walk on. DDH is a very frequently missed diagnosis, and especially in our population because it is so uncommon. So it ranges from as subtle as a tabular dysplasia to frank dislocation of the hip. It commonly affects firstborn females with a breech presentation and a family history of hip dysplasia. And it is extremely uncommon in the Black African population. Clinical examination of the patient with potential DDH will demonstrate a short leg Trendelenburg limp, the leg length discrepancy, and asymmetrical abduction of the hip as seen in this young boy. Early signs or signs in the neonate will be a positive Ortolani or Barlow test, and both clicky hips and asymmetrical buttocks and thigh creases are an indication for referral for ultrasound to exclude hip dysplasia. This image here demonstrates the Ortolani and Barlow tests performed to examine the patient's hip. The Barlow test is if the hip is reduced but you can dislocate it, and the Ortolani test is if the hip is subluxed or dislocated but reducible. Coxa Vara is an uncommon condition but can present very similar to DDH, with the patients presenting with a short leg Trendelenburg limp. This girl was actually referred to the spinal clinic because of a query scoliosis. This is a scoliotic X-ray showing an abnormal hip and a clear oblique pelvis. So this is Coxa Vara. As you can see, the angle of the neck and the femoral shaft is decreased, and there's some abnormalities in the physis. So long leg X-rays were taken that confirmed the significant leg length discrepancy, the oblique pelvis, and the underlying hip pathology. So lastly, if a patient doesn't present with pain or limping, they will present with a deformity of some sort. The most common coronal plane deformity that patients will present with will be knock knees and bow legs. So children undergo natural variance as they grow older. Most children under the age of 1.5 years will have a degree of tibial varus or bow legs. It's often associated with in-toeing. In the 4 to 7 year group, knock knees are quite common, and we usually say they should be straight by 8. So bow legs or genu varum is not normal if it persists beyond 2, if it's worsening, if it's asymmetrical, if there are other associated deformities, or if the patient demonstrates an abnormally short stature. This is a patient that presented to me with bow legs, but upon examining her, I found that she also had an abnormal gait with a Trendelenburg limp bilaterally, and her X-rays revealed features of rickets, such as widening of the physis and bowing of the legs, and she did indeed have hypophosphatemic rickets. Blount's disease is by far the most common cause of bow legs in our population. It's caused by an isolated proximal tibial defect and usually occurs in slightly overweight children with who started walking early. It is progressive and surgery is always indicated. Knock knees are considered a normal variant in children between the age of 4 to 8 years. It is a painless deformity which should alert you to an underlying cause if there is in fact pain, and parents usually present or bring their children to the doctor because of cosmetic concerns. Treatment is indicated if it's gross, if it's a gross deformity, or if it's worsening, or if the patient is older than 8 years old or younger than 4. And it's important to think of underlying causes when you examine. This is a young patient of mine with Morquio syndrome, which is one of the mucopolysaccharidoses, and patients with Morquio typically develop genu valgum. This was him before treatment, and then you can see there after treatment he's straight as a rod. And how we achieved that was by a procedure called guided growth. It's where you perform temporary hemiepiphysiodesis at the concavity of the deformity, and this allows the other side of the growth plate to grow faster and for the deformity to correct. In this patient's case, the deformity took 1 year to correct. In-toeing will be the other very common reason for referral to a general practitioner or chiropractor. It is quite common, especially in girls, and parents usually present because of cosmetic concern about the in-toeing. Patients often get teased if they walk like that, and this can have quite a significant psychological impact. If very severe, the patients may report frequent tripping and falling over their own feet. So the first thing you look at when the patient presents to you with in-toeing is something called the foot progression angle. In this clinical photograph, this patient of mine, you can see both his feet are turning inwards when he walks. Most people will have a slightly externally rotated gait, and this is normal. Tibial torsion can be assessed by looking at what we call the thigh-foot angle. You position the patient prone on the examination couch and flex the knee 90 degrees. You then measure the angle subtended by the long axis of the thigh and the long axis of the foot. This is also usually slightly externally rotated, as is illustrated in this graph. And lastly, you look at the femoral torsion. The easiest way to measure this is your internal and external rotation range. Remember, when a patient is lying down with the knees flexed and the legs turn out, you are actually measuring the internal rotation of the hip. And similar, when the legs go in, it's the external rotation of the hip, as illustrated here. This is a condition, miserable malalignment, that is characterized by internal torsion of the femur and external torsion of the tibia. It may not be too clear in this X-ray, in this clinical photograph, but with the feet pointing forward, the patellas are actually pointing inwards. Patients with increased femoral anteversion or miserable malalignment would typically sit in a W position by choice and will demonstrate significant internal rotation on examination. Please note that sitting in a W position does not cause femoral anteversion. It is a result of femoral anteversion. Therefore, if a patient sits like that, there's no reason to discourage them from doing that, as it is merely a result of the shape of their hips. Okay, metatarsus adductus is a relatively common disorder. It's a packaging disorder, therefore associated with conditions that cause decreased intrauterine space, such as oligohydramnios, primigravidas, or multiple pregnancies. It's important to check the hips, as there can be associated hip dysplasia or dislocation. And initial management usually consists of reassurance, simple stretches, or reverse shoes. 90% will resolve spontaneously by 4 years. Rotational deformity of the tibia and the femur is less common, and unfortunately the surgery is always the only treatment available is surgery. However, spontaneous correction of increased femoral anteversion can still occur up to the age of 10. And this is a patient that I did operate on. So as you can see here, feet pointing forwards, patellas pointing in, and she had bilateral femoral and tibial derotation osteotomies, and here she now has normal limb alignment. And that concludes the talk. Thank you very much for your attention.